Good morning, ladies and gentlemen, the chairperson, Dr. Anand, Tilak, and Smita, the senior faculty, and the postgraduates. I consider this as a great honor to me to give this oration. When we started what to talk, my team told you have spoken most of the things. Why don't you talk about the journey itself? So I'm going to talk about my journey in plastic surgery. And it was not as placid as the water which you see there. There were turbulences and difficult times. However, it's a long journey. I may take a few more minutes. The chairperson will oblige and all of you listen to me patiently. Greetings from SDM Dharwad. From where shall I start? From the beginning of the beginning, as Alice in Wonderland said. I did my MBBS and MS from Kasturba Medical College, Mangalore and Manipal. Of MS. I was dreaming to become a cardiac surgeon or a neurosurgeon. Final year of my MS, one Professor Dr. Naik visited our unit in Mangalore and gave a lecture on hand and reconstructive surgery, which really made me to take up plastic surgery. At that time, the plastic surgery is not one of the sought after branches. Cardiac, neuro was the main one, then the urology. But always listen to your heart. It always guides you in the right direction. So I took up plastic surgery and I was lucky to get in MCH in Madras Medical College under Professor C.R. Sandarajan, and again Dr. U.S. Naik was there, and Professor Venkat Swami was the chief at that time in the Stanley Medical College. Professor C.R. Sandarajan is probably the founder of MCH in the South. A man of the great principle. He not only taught me the principles of plastic surgery, he also taught me the principles of life. A very straightforward man, honest and very humble, and this is what I learned from him. And when I joined, my senior was Professor Gurumurthy, I think he's around, and my colleague was Dr. Changam Joshua. And that was a very exciting period of the plastic surgery, because till then, most of us were doing very conventional flaps. And I joined the institute little late, so I couldn't get a room. And I had a difficulty in getting a room. I told my chief, I have problems, sir, I don't have a room. Then he went and spoke to the Princey, and by vengeance, I think they gave us a room under the stairs. And I had a room at a brilliant student doing his general surgery residency at the final year and dreaming to become a neurosurgeon. So when I asked him, why you want to be a neurosurgeon? He said, today I assisted my chief. He was doing a bypass from the extracranial to intracranial surgery and exciting view through the microscope. I said, look here, there is more microsurgery in plastic than neurosurgery. So that was Professor Raja Sapapati, and then it's a history. I'm very glad that I converted him into a plastic surgeon. And till then, it was conventional flaps and random flaps and difficult times to rise in big flaps. The plastic surgeon realized they had to do something, understand the blood supply to the skin better. So they went back to the anatomy and they found the axial flaps. Then they found the myocutaneous flaps. Then they found the fasciocutaneous flaps, perforated flaps, and angiosomes. These are the cross-leg flaps, which are very difficult ones. And the groin flap was the one axial flap became very popular during that period. At the same time, on the other hand, microsurgery became very popular and got established. And I came back in 1981, and three things happened which was fantastic for me. One, as I got married to Lata, a lovely lady, and she stood with me all my difficult times. And I joined Kasturba Medical College, and I worked with Professor Y.S. Rai, one of the brilliant plastic surgeons I have worked. I learned a lot from him about the cleft lip and palate. And that's the time he designed his famous ray mouth gag. Unfortunately, he didn't get the credit which he deserves. After joining the Kasturba Medical College, it's usual that we all start practicing private practice. So I got hold of a room for my consultation, and I wanted to put a nice board. So I asked Tangam, said, I know someone, he will make a board for you nicely, come with me. So I went with her, and I gave the materials. These are the materials I want. Then he just looked at me and said, two things I want to know, whether you want this to be in the marble or in the granite, and you're not told about the years. Then I just looked at the Tangam, and she looked at me. Then I came to know that he's a tombstone maker. Well, then I realized my private practice has come to a standstill. I was not very happy with my work. I was not getting good results. I had failures in my hand, and I was worried about it. And probably those failures are the good thing what happened to me, and I realized obstacle is the way. So I wanted to learn more about plastic surgery, and I want to tell the youngsters, it's a long journey. You have to get trained for a long period. I was interested in microsurgery, craniofacial work, and cosmetic surgery. So with that, I went to England. I worked in some of the very good centers in the Scotland. Mainly I was in the Scotland. And I had micro training in Canisburn Hospital, which is sort of a mecca to the plastic surgery. And you have to say that as we looking for a good teacher, you look for a good mentor. The teacher also looking for a good student. So when the student is ready, the master appears. That's the Zen saying. It goes, then again, when the student is really ready, the master disappears. Most of the time I spent in one of the hospitals called Ninewell Hospital. As I said, you have to work very hard. You have to work really hard during your training period. Those who sweat a lot in the training bleed less in the battle. This is the saying from the Spartans. It goes good even to us. Those who sweat a lot during the training, they bleed less in the theater. And we all know what we want to get from the unit. We want to learn something, we want to get something and others. But at some time, just look back and see what the unit wants from you. Then the magic happens. Just like if you put a little water and fertilizer to the tree, it gives hundreds of fruits. The same way the unit gives you a lot. When I finished my training in 93 and I wanted to come back to the India, and I told the chief, he was very happy. And as I said, they gave me this microscope and a set of micro instrument as a gift. And it's still working, it is still with us. So always think what the unit wants. 93 I came back and I joined Manipal Hospital and started working there. During those days, I have to say, the administrators never thought much about the plastic surgeons. They used to think some small things we have to do, some skin graft and burns and other things. So he didn't give me any assistant, so I was doing the work alone. But however, my passion, I started doing reimplantations right away, and the fingers and the hand. Now, at that time, what I felt as a peak in plastic surgery, probably it is now routine for most of you. I put back the hands and put back the forearm and even put back the foot. I'm putting this mainly because how difficult it is to create slides in those days. And the reconstructive surgery always interested me. This is one of the nose we reconstructed. I think Anand will remember. Then, one day I got a head and neck case nearly after 6 months to do a reconstruction of the tongue following CA. Incidentally, again, it's from Dharwad. I didn't have any assistant. So I asked my colleague, my classmate actually, Professor Vasudev Rao, a vascular surgeon, to come and help me in doing this case. So I did the case, and by God's grace, it went on well, and he got discharged. So I went to the billing section and asked how much I would put my charge for the collection of the fees, professional fees. He just looked at me and said, smiled, "Sir, your return is free flap. So patient is gone home." So that became my first free flap. And the free flap is the first coined by Ian Tyler. Then, those days it was very difficult to reconstruct the bone. We were using mainly the radius, iliac crest, and sometimes scapula, and all leading into a lot of morbidity of the donor site. Once the fibula became popular, that became the workhorse for the bony reconstruction. And those days, we were not very sure how much we can take the skin with the fibula. So in the beginning, we were not harvesting the skin at all. This is one of the first fibula we have done. This is a fibula done for the a benign tumor, and that's how it really gets strong and thick. And we started putting this everywhere, into the tibia, into the femur, into the humerus, and into the neck also. That is one of the disappearing bone syndromes. And cosmetic work kept on doing, breast augmentation, breast reduction, and rhinoplasties. In rhinoplasties, I want to tell the juniors one thing: give what the patient wants, not what you want. And as the journey goes by, it was difficult times working alone, but I was lucky. 1996, 97, I think, Anant joined my team, a brilliant plastic surgeon and a solid guy to have as a team member. Then one more, we created a team. We joined hands with the neurosurgery, and Dr. Sujay Rao, a tall neurosurgeon with a brilliant work and fantastic in surgery as well as in computer work, joined, and we created a team called as Neuroplastica, a skull-based surgery team. Now, what is skull-based surgery? And it kick-started by Jackson, who visited our unit and did few workshops for us. So we started this journey of skull-based work. The skull base is an area which separates the neurocranium from the face and aerodigestive tract. Any tumor in this area are deep-seated and difficult to reach. An adventurous surgeon, if he tries to make recklessly to reach this area, he's going to end up in difficult times. He will be disfigurement, infection, and devastating neurological deficit because of the retraction of the brain, which produces fantastic edema, and can lead into cerebellovenous thrombosis, strokes, and anesthetic problems. At that time, the long surgeries are not very familiar. Now, what we learned from the craniofacial, we applied to the skull-base work. Eyes can be isolated and moved in all four axes. Extensive basal exposure prevents brain retraction because the edema happens in the face, not in the brain. Extensive free bones. Most of us think that such a big bone we remove and we put back without any problems, and it takes, and reconstruct with the bone. And vascular tissue transfer. See, what happens is if there's a breach in the skull base, the aerodigestive tract gets exposed to the cranium, and the infection can go up and destroy and kill the patient. So you have to put a vascularized flap there. Either you can use a pericranium, glabellar, and even free tissue transfer. Now, this is one of the approaches we call it as a facial translocation. It is mainly advocated by Janaka. It's a modular approach because you can expand it as you want. And it goes along, the incision and the osteotomy goes along the optimum line of separation. That's exactly like the growth of the face. And the sutures and the scars falls between the aesthetic units, and blood supply to the face is not disturbed. And the hollow structures helps in reach the area very quickly. And because the retraction is not done on the brain, there's no brain edema, and you can put back all the bone and get the anatomy back. I'll just show you a few. And facial translocation, anterior mini, standard, extended, and bilateral. This is the mini one where we remove the zygoma, maxilla, part of the nose, and the tumor is removed. And whole thing is put back and sutured. The second is the frontomaxillary osteotomy, where the tumor is spread from the anterior cranial fossa to the maxilla and to the nose. We do a bicornal incision, bifrontal craniotomy, and facial bipartition, removing the nose part of the maxilla, and it's a combined approach, removing both from the cranium as well as from the maxilla. This is what I told about the pericranial flaps which we harvest and which can be used both for the flap as well as to cover your plates. This is the post-op. And extended approach when it is like this. Here you can see the eyes in the totally in different direction, but still his vision is intact. The lateral approaches are much more difficult. It can be transtemporal, infratemporal, transfacial, and intracranial. I will just show one of the Fugo fish approach. the upper incision for the craniotomy, and the same on what you do for the parotid, and the lower part is to get the control on the carotid vessels. You do a facelift incision and lift it up. You do a superficial parotidectomy, zygomatic arch is removed, mandibular osteotomy, craniotomy, and remove the tumor and put back everything. That's what it is. And Trusons are something very fantastic to do. And once you correct, once you do a fronto-orbital advancement, you give enough space for the brain to expand, and also cosmetically they are much better and they can lead a normal life. This is a late post-op. And this is one of the first Trusons what we did. Here I want to say two things. One is I lost the pre-op pictures. Preserve your pictures as much as possible. And this is why I am showing mainly because how back we put the bicornal incision, and it gives a fantastic approach. And in the later part of the life, when they lose the hair, still the scar is not visible. And this is one of the milestones. It's a craniophagus. We did the separation, and this is done in Kasturba Medical College, Mangalore, under the leadership of Dr. Muralidhar Pai, Dr. Y.S. Rai, Anand Kini, and myself. And now they're grown up, and one is getting ready for the marriage. It took 48 hours. And again, this is a milestone in my life. I did the APRASCON 2002 conference in Bangalore. At that time, Anand was with me, and many of the others are there, Tilak, and probably quite a few of them, Babu Bajandri and Satish, everyone was there, and it was a fantastic time. It was one of the landmark because that's the first conference, first fully digitalized conference. I think I have to give some credits to Raja because he's the one who put the idea to me. And I have to say, when I came back in 1993, the Indian Airlines went on strike. And there was no transportation for me from Bombay to Mangalore. So finally, I stayed there for one day, but I was eager to go back to my hometown. Then they said, there's a bus going to Dharwad. If you want, you go there. It is an ordinary bus. But then I said, I have some relatives there. They will give me a drop. So I went to Dharwad and landed there early morning. When I saw this, I was taken back a little. I said, hope I don't have to practice here. But then, this, I think, those who read Kannada can understand. This is a very famous poem by Rabendra. In life, the only certainty is uncertainty, which I thought I don't have to go there, and the last 25 years I am in Dharwad. And sometimes I just wonder, God has got a peculiar sense of humor, and whether it is just a cosmic joke. Now, I left Bangalore, my unit which I nurtured and very lovingly developed. I have to go to Dharwad. But I'm happy that still the unit doing very well under the leadership of Anand. When I went there, I have to learn many things. Not only about administration, I also have to learn a little bit of civil engineering and a little bit of finance. But I have to tell you, I think you have to learn about the finance. Very important. I thought, do I have skills of administration? My family thought otherwise. But however, once I realized I do have a flair for administration. Now we talk about the work and life balance. I am juggling with many things now. And the clinical work, which I am still very active. I am doing the academic work and administration as a Vice Chancellor, and I have to deal with my family also. When you finish your work late in the night, when you go home, the day starts for the family at that time. Maybe your wife and children are waiting, and if they say, let's go for a dinner, you should gather all your energy and take them out. Now, I have a very young team supporting me, Dr. Avinash and Dr. Anil, and that's a photograph with our Chancellor. I have to say that my things changed when I went to Dharwad. I had to adapt to the situation. So you have to adapt and flourish. I'm doing more and more cleft lip and palate, a lot of head and neck reconstruction, and the trauma. But the trauma what we get in Dharwad is different, most of it because of the agriculture injuries. Cleft lip and palate, we have done more than 10,000 cases in the last 10 years with collaborating with Smile Train. And when you do this, and when the child comes back and smiles, that's a great feeling and gives a great satisfaction to all of us. And I have to say that what's very important for you, is it success or satisfaction? The success is always judged by outsider, and satisfaction something what you get at the end of the day. That's a cleft palate. One more thing I want to tell the juniors. Don't give up cleft lip palate. Don't give up hypospadias. Don't give up maxillofacial surgery. Don't give up hand surgery, burns, because our seniors have worked very hard to develop the skills and refine it. Now, if you just throw it away, it is very sad. And once you do a lip, they are your patient for at least for the 10 years. He came back for the nose correction. And we do get a lot of head and neck construction for oral cancer. The oral cancer is the most challenging for any reconstructive surgeon, because you're not just reconstructing. What you reconstruct should be functionally good and aesthetically pleasing. The radial forearm flap is one of the most commonly used in the beginning. And I say that this is a flap which established microvascular surgery, this in the head and neck reconstruction, and LD in the limb reconstruction. This is pliable, thin flap, goes very well for the lining reconstruction. But we do get patients which are very advanced. The lining, the support, and the cover is destroyed. Then we go for ALT free flap. But nowadays, we do this for all the cases more and more, and radial forearm is taking a little backseat. And of course, with the fibula, things have become much easier. And with the 3D printing and planning with the jigsaw, it becomes very important, and we can get a very good results. This is the lateral reconstruction of the mandible. Central always is the most difficult ones. You may have to do 3 or 4 osteotomy to get the right, but you can get a very good results. Maxilla is again a difficult area to reconstruct. Again, you can use the fibula with the skin paddles, or sometimes we just reconstructing use the soft tissue. This is a challenging case came to us. A 14-year boy looking like a 6-year and with a 3-gram hemoglobin. And he has gone round. I think everyone's scared to remove this. So finally he sat in front of me and cried. So we took a decision and to do it. We went in and removed this and reconstructed at that moment with the implant, planning to do it with the fibula in the next stage. But unfortunately, COVID came in between and he succumbed to that. And reimplantation goes on and on. But the injuries are mainly from the harvesting machines. And this is an interesting case. I think yesterday it was presented by our postgraduate. The 18-month-old child, 4-foot reimplant, probably the second youngest in the world, reported if I'm not wrong. And the challenges were fixing the bone, right from the fixing the bone, because the bones are not well developed. And the vessels are very small, and the veins especially they're difficult to do. And we got reasonably good results. You can see the child is walking. And there was some little varus deformity which was corrected by the orthopods with the serial plastering. The rest of it done by the nature itself. And lower limb trauma here we get is from the agriculture injury. This is a tractor injury. The principles are the same. A thorough debridement under tourniquet, and you cover it as early as possible. Probably LD is one of the commonly used for the big defects. And do the anastomosis above the zone of injury, as Mark Godina said. And to the mid-size, we can use a gracilis. And the small ones, we started using MSAP. Diabetic foot is one thing I think we should concentrate on. Most of us don't touch it, but actually it is our field. And most of the time it is not properly handled, not investigated properly. Look for the vascularity and the nerve injuries. And luckily, our patients, the vascularity is not too bad. But the important thing is the weight distribution is incorrect. So you have to correct that by unloading surgery. Then you put the flap. Otherwise, your flap goes. Here, in spite it looks so bad, we did a thorough debridement, we put a LD flap, and it went on well. Now, as we grow old, we get into a comfort zone. We don't want to do something very challenging. We want to be within our own field and be happy with that. But then the magic happens when you jump out of this comfort zone. And challenges were the brachial plexus injuries. This is a birth injury. We did the exploration and most of it recovered except the elbow. And we did a small procedure, stintless procedure, which gave that results. But then when you have a global palsy, it's much more challenging. And to someone who has nothing, a little is a lot. And what we do is, now we start doing the contralateral C7 and a vascularized ulnar graft. And we use accessory to suprascapular. And this one to the musculocutaneous, radius and median now, and intercostal for the triceps. We do get reasonably good results. Is in the recovering stage. Now comes, what are we? Who is a plastic surgeon? I keep asking quite a lot. And to surprising, even my own family sometimes wonder what the hell I'm doing. And some people call us as dustbin surgeons, anti-gravity surgeons, and many things, and creative surgeons. But most of all, we are the friendly surgeons. When someone is in trouble, we go there and help. We have done sternal descents quite a lot. Probably in Manipal, we have done more than 50 cases, myself and Anand. And when our transplant team, kidney transplant team, the transplant surgeon left, and they were a bit devastated what to do. They had a long waiting list. Then we said, you don't worry, we are there to come and give you a hand. So we started going to the transplant team, and now we have done more than 80 cases of kidney transplant. We do the anastomotic part of it. Now comes from my other side, and a hospital and medical college started in a small way. We have now 1,500 beds, and we have started all the post-graduation, including super specialty. And our university came as number 1 emerging university in the country. And even our college and other colleges, ancillary like dental, physiotherapy and others, are within the 10 in the country. Then how we achieve this? Anything when you start, even your own profession, you should have a very strong why. Why? Any institution or any industry which has reached above head and shoulder of others, because they have a very strong why. That's why they reach this. So ours was very simple, only 2 things we had. One is that any patient coming at any time, day or night, without real money, should get the best treatment possible. And in Kannada we call it as Sri Samanyanige Rajopachara. And any student joining our institution should get the best training possible. And that's why, if you have a strong why, then you know how and what to do. So, to the youngsters, you have to create a team as you grow old. Because most of us started alone, single-handed. But as we grow, people come and join. Having a teammate, your stress comes down more than 50%. You be honest, mostly to yourself. There's no shortcut in surgery. And do the right thing always, not the easy thing. You live without fear, conflict and comparison. The fear of failures, fear of tomorrow, fear of losing ones. Love your job, then you don't work for name, fame or money. And incidentally, all of them comes to you. Nobody can force you to do the surgery. Don't allow anybody to force you to do the surgery. Nothing becomes easy even after many years. Not the life, not the vessels. Still the vessels behave peculiarly. Always share the glory. Take the blame. And never hesitate, ask for help. Asking for help is not giving up, said the horse. It is refusing to give up. Ego is your enemy. That's what prevents you from asking for help. Be humble. Very important is be humble. But then, can you be humble without trying to be humble? Can you be humble without trying to be humble? Read. Readers becomes leaders. Read voraciously. Life is much bigger than profession. Develop a hobby, keep yourself fit. You should operate and also teach. You should operate and also do the research and publication. You should operate and you should travel and have fun, because life is fun, it should be fun. And learn basic about the finance and be spiritual. So achieve your goal and use it, help others. That becomes your purpose. And I want to be thoroughly used up when I die. For the harder I work, the more I live. I rejoice in life for its own sake. Life is not a brief candle for me. It's a sort of splendid torch, which I have got hold for the moment, and I want to make it burn as brightly as possible before I hand it over to the younger generation. And I want to thank my parents, my mother. Because of them I am here. I thank my teachers because the proper guidance and taking me through the right path. I thank my friends because they were there whenever I wanted. I thank my team. If at all what I achieved, it's because of my team. And I thank my family for tolerating me. And Lata took care of the whole thing so that I can go and do the work which I enjoy. Thank you very much. I never thought I will be emotional, but it's very nostalgic. Thank you very much again.